Good afternoon, everyone. Thank you for joining us. This is the last implementation webinar in a series that we've been presenting based on a project funded by PCORI to disseminate findings from several large recently completed dialysis research studies. Welcome to today's webinar presentation for ESRD network staff that will describe an advanced care planning program developed for dialysis social workers. I look forward to introducing today's two speakers. Ginny Kitson has over 47 years of experience in the field of end-stage renal disease. She started as a medical social worker at Yale New Haven Hospital, and she was a member of the original dialysis and transplant team for 10 years. And then for the next 35 years, she served as the executive director of the ESRD network of New England that covered 6 states. Currently, she's retired and recently has participated in 3 different stakeholder committees that involve patient empowerment and end-of-life studies. Her personal recent experience of being the only family support member for her older brother who was on dialysis for 6 years in a nursing home before he died has contributed to her strong commitment to advocating for shared decision-making and respect for patient choice in their life goals. Dr. Joan Berzoff is a professor emerita at the Smith College School for Social Work, where she co-chaired the doctoral program and directed the end-of-life certificate program. She's written and co-written 4 books on end-of-life in multicultural settings, and she's been awarded the Outstanding Teacher Award from NASW, the Outstanding Writing Award from the Association for Psychoanalytic Social Work, and the Social Work Leadership Award from the Project on Death in America. She teaches in the doctoral program at the Institute for Clinical Social Work in Chicago, and she has a private practice in Northampton, Massachusetts. As usual, for attending this webinar, 1 continuing education credits available to all nurse and social work attendees who pre-registered and who attend today's event, including filling out the evaluation form at the end. If you are only joining by phone, please send your phone number to Heather Cecil at hccil@qualityinsights.org so she can verify your attendance for your continuing education credit. These will be mailed to each attendee who meets the pre-registration and attendance requirements within a month of this event, and they'll be mailed to the email address that you signed up for. Please, we really encourage you to post any questions using the Q&A icon at the bottom of your screen, and we will try to get to as many of these as possible at the end of the presentation. So now I will turn it over to Ms. Kitson and Dr. Berzoff.
Well, hi and welcome. It's a pleasure to not see you all, but know that all of you are there. What we're here to talk about today is advanced care planning, and to really talk about both our study and also implementation of advanced care planning, especially in the time of COVID. We are talking about it, of course, because we are not immortal. We know that the only things we can count on are birth and death that are universal experiences. And so advanced care planning is incredibly important to us all, but also important, obviously, for patients and families. So next slide, please. What we wanted to do today is to describe the current state of renal social work advanced care planning, and then to take you through in a very quick and cursory way the educational content that we developed that we thought was essential for social workers to be able to take leadership in advanced care planning. We wanted to touch on some of the challenges for implementing advanced care planning right now in the time of COVID. And then we wanted to make implementation recommendations for all of you in the field. Next slide, please. So what do we know? We know that kidney disease is life-limiting, and it's a multifaceted, long-term chronic illness We know that 600,000 patients are on dialysis in the United States, and the mortality rate is almost 36%. So that means that a lot of people are dying, and yet it is often the case that advanced care planning doesn't take place consistently in dialysis clinics. Next slide, please. Ankar, next slide, please. All right. In terms of the literature, what do we also know? We know that end-of-life conversations don't routinely take place. There have been many studies that tell us that many renal patients do not know about advanced care planning. And maybe partially, the research tells us that has to do with patients who are afraid to discuss advanced care planning with their nephrologists. And often patients are afraid to discuss advanced care planning with their families, and often staff are afraid to discuss advanced care planning with patients and with families. So everybody is in some way complicit in colluding to avoid what are very difficult conversations, and ones that have to take place not once, but many times over. We also know that there is a complicated trajectory of comorbid conditions. And so patients are often hospitalized, end up in nursing homes, have emergency room visits for diabetes, for heart disease. We also know that there are many cultural and spiritual differences between practitioners and patients and families that also get in the way of comfortable advanced care planning conversations. The research and literature also tell us that, in fact, social workers are not institutionally supported to do advanced care planning. And we also know from the research that social workers are not trained in schools of social work around advanced care planning. Next slide, please. So there are other barriers as well to advanced care planning. There is, as you all know, far better than we, time is in very short supply, and all the more so in the time of COVID. There is a lack of private space to have these kinds of conversations. And there are many barriers and impediments to integrated advanced care planning. So you can have a wonderful advanced care plan, but when a patient ends up in the emergency room or in a nursing home or in an inpatient facility, the plan goes out the window for HIPAA reasons and other reasons. And that really can cause a serious barrier to helping patients and families realize their advanced care wishes. Next slide, please.
Okay, this is me. Hello.
Yep.
This is Jenny speaking. Thank you for inviting us to do this program with you today. We just wanted to give you a brief overview on the structure of the study that we were participating in. It was funded by the Patient-Centered Outcomes Research Institute, which is government funds as well as private funds. And the idea is that they are looking for studies that are community-based, that actively involve patients as well as stakeholders in designing the study. So this is a unique approach that the government is promoting to try to make sure that everyone is participatory in the design of the study. The project that we worked on was a 3-year study that was conducted in 2014 through 2017. And we had 18 sites, basically 18 clinics divided between New Mexico and New England. The goals of our study were obviously to increase end-of-life planning and hospice referrals. You may recall that the data indicates that end-stage renal disease patients, dialysis patients, are not referred at a very high rate to hospice, and there's maybe some technical reasons, but also when you think of the chronic illness and the trajectory of knowing that this is the ultimate outcome for the patient, that there should be more planning. For example, cancer patients, there is a referral rate to hospice of about 50%, And with dialysis patients, the range is around 20 to 25%. So you can see that there is quite the difference. We're just not getting to the subject matter, as Joan was pointing out. And we would like to, obviously the goal was, our model was to make sure that the social workers, because of their skills, should take a leadership role in doing the planning. Next slide. What we wanted to do was to get some advice and information as the study design was stated on how we might recruit the patients that we're going to be working with. So what we did was we had a team that helped us design the study, and we recruited 125 patients from Massachusetts and New Mexico, as I mentioned. And you can see that the diversity of background and cultures was extensive, and that was our intent, so that we can understand cultural diversity as well as perhaps spiritual and economic barriers that patients might have. In New Mexico, we had largely Mexican and Native Americans, and in Massachusetts, we had white population, Puerto Rican, and African American. The criteria for this particular study was to identify high-risk patients, those individuals who were expected to be dying within the next 6 months. We had a prognostic tool that allowed us to do a scaling of the patients so that we could identify who these potential patients might be before we approached them and asked them to participate in the study. And on that questionnaire and survey, as we were recruiting the patients, we had a question about would they be interested in knowing what their prognosis was. And 86% of the patients enrolled in the study said that they would indeed be interested. We'll get to that later, asking them in the abstract if they're interested versus actually having that conversation revealed a slightly different level of interest, let's put it that way. Okay, next slide. The overall results of the study, because the intervention period was different based on how frequently we were able to recruit patients on a staggered basis over the 3-year period. So when we looked at our overall results at the clinic level, we really did not see a difference in the rate of referrals to hospice at the clinic level. It ranged around 25%, which, as we were telling you, is basically what we observed on a national level. However, when we looked at the patients that did participate actively in our study, and that should be a percent sign, 48% of the patients that participated in our study actually did stop dialysis prior to death, and 43% of these patients received hospice services. So you can see, having the conversation opens up the opportunity for patients to make choices and decisions about their quality of life and what they want to have in terms of their treatment options at the end of their life. Our sample size, as we stated, was 125 patients. The median age was 70. 51% were male, 12% African American, 14% Native American, and that is another typo, forgive me. It should be 46% were white and 37% reported Hispanic ethnicity. With regards to using the tools and actually participating in making decisions, 75% of the patients who were in this project and completed the study with us completed a healthcare proxy. 63% completed the MOS or post life-sustaining orders that many of you are familiar with. It's different in each of your states, but this is decision-making in terms of what their life-sustaining orders would be. So next slide. Our part, Joan and I, were involved in actually trying to put together, I shouldn't say try, we did put together a study program and training criteria for this particular study to allow the social workers to take the lead in advanced care discussions. Before we were doing that, we actually reached out and talked to patients and focus groups, nephrologists, and others to get an idea on what it is that we should incorporate into our training tool. And the comments that we heard were that they wanted us to have some way of making sure that the social worker could be a better advocate for patients within the organizational structure of their clinic and within their corporate organization. Practice needed to be a greater attention on, and we needed to know more about the cultural and spiritual differences of our patients so that we could articulate what that means in terms of making decisions about end-of-life care, more knowledge about the legal and ethical issues that are associated with advanced directives, living wills. Again, these vary from state to state, but there are some overarching principles that could be addressed. Learn to break bad news. Having these conversations is always difficult, so it's just learning how to be comfortable and finding the language that demonstrates empathy and concern with patients. Increasing skills and working with individuals and the family members, having these conversations takes practice. Be more adept at addressing countertransferences, resistance, compassion, fatigue, and burnout. That's obviously getting to the self-care of the social worker, having to work with this difficult population, as well as these topics that are emotionally draining. More effective more effectively, assess and address structural barriers and team conflicts. We discovered that the culture within the different clinics, as you probably well know, vary, and that there are differences of opinion in terms of how much conversation one should be having with patients with regards to making treatment options for themselves and being in charge of making those decisions, and who should be doing it and how does it happen. Okay, next slide, please.
Okay, it's Joan again. It's me again. All right. So what do we do? Our intervention was to develop, out of all of this data that we got from social workers and from patient advisory groups and others, we took the data, we analyzed it, and then we developed what was an 8-hour training program that was didactic, by which we mean we had faculty teaching social workers, and we had a video conference going in New Mexico and in New England with 5 faculty members, a palliative care doctor, 5 social work educators, and a lawyer. And we broke up the day and the curriculum into 4 modules. And the first was really, how do we practice? How do we communicate bad news? What does that bring up for us? What kinds of skills are needed, and what kinds of issues do we need to address in terms of self-reflection, self-knowledge, countertransference, et cetera? Another module was on leadership. What is leadership? How do we assess what's going on in our organizations? How do we address organizational barriers? How do we advocate for families and for patients? Another module was around cultural and spiritual issues, and the last was on legal and ethical issues. But it would be extraordinarily boring to just listen to talking heads all day. And so we developed a number of case studies in which we interspersed and interwove all of those modules and applied them to 3 cases, so that the social workers could break up into small groups during the day and discuss these cases and discuss the legal, spiritual, cultural practice and leadership issues. Next slide, please. So a little bit more about what was in the practice course. We're going to show you the video that we showed to them about breaking bad news, and we'll show that to you in a minute. But what we didn't do then, what we would have done now, is talk about the challenges of telehealth and Zoom as a method right now for talking about advanced care planning and how complicated that can be. But in our training program, we train people to really listen for and elicit patient and family wishes. And also, these are not conversations, as you know, that take place once or twice. They take place over time, many times. And so we really emphasize the importance of following up as wishes change and the disease trajectory changes. We also encouraged our social workers to talk about what gets stirred up for them in advanced care planning, because it is about our mortality, it's about our patient's mortality, but also about our own. And we are human beings and we have intense feelings around death. And we have many resistances to talking about death. So opening up the space to talk about that was really important. And also opening up the space again to talk about some of our countertransference reactions, some of our feelings that get evoked from patients. Maybe aversion, maybe hate, maybe sorrow, maybe grief, as well as how this wears us out, our compassion fatigue, and how if we don't deal with what we're feeling, we can often burn out. Next slide, please. So that was one module. Again, the cultural and spiritual issues. We had a spiritual assessment tool, and you will find that in our bibliography. But it's really important that we assess where a patient and family are coming from spiritually, because spiritual, cultural, racial misunderstandings really do erode trust between patients, families, and practitioners, and often can lead to patients and families turning away or shutting down and to non-disclosure. It's very important, and we talked a great deal about power imbalances that are naturally embedded in these conversations when you have patients and families who may be people of color, and often you have white practitioners. And though it may not be entirely visible, there are deep power imbalances. We talked about techniques for bridging cultural and racial divides. And again, we spent extra energy and time on Latina, Hispanic, African American, and Native American groups, and how they make decisions with families that may be different from white families. Okay, next slide, please. In terms of legal and ethical issues, we reviewed those things that you probably know: informed consent, living wills, what surrogacy means. But we also talked about some of the ethical principles that guide decision-making, and they are not always congruent with different cultural groups. So autonomy, for example, is not necessarily the major value in African American, Native American, Latina families, for example, where interconnectedness and interdependence is much more the norm. We talked about decisional capacity and, again, ethical decision-making. Next slide, please.
This is mine?
Yep.
All righty. This is the intro into actually showing you the video that Joan just mentioned. We had a template for social workers so that they made sure, with the nephrologist participating also in the family meeting, so that they would make sure that they could touch on each one of these topics, so that we would have some consistency in evaluating the impact and the usefulness of this format. So when you're watching the video, just keep in mind that the points that we wanted to make sure that were addressed were making sure that we had some sense as to what the patient understood with regards to their own particular disease status. We wanted to acknowledge, did they really want to hear more information about the prognostic course of their illness? Have an opportunity to explore with them a little bit about their life goals and tasks that may not have yet been completed that are important to them. Offer, depending on where the conversation goes, end-of-life tools and resources that they can take with them to evaluate and look at. I know under the conditions of coverage, we're all required in the clinics to make sure that they have advanced care directive information given to them, but frequently it's just sort of handed out to them at the beginning of dialysis when they're first overwhelmed with so much information, just learning about the treatment course and what's happening, that it gets ignored and somehow it never quite get around to going back and following up on it and having meaningful discussions. So this is an opportunity to reintroduce some of that material or new material. And then we wanted to confirm the understanding of the patient with regards to what it is that they heard that was really discussed during the meeting that was just held, and then set out plans for the next steps. So if we could have the video, please. Keep in mind that this is not a major production, it's a training tool, so this is role playing, forgive us.
Sue is a 69-year-old woman who has a history of end-stage kidney disease secondary to diabetes. She also has high blood pressure and coronary artery disease and receives routine hemodialysis in our dialysis unit. Last year, Sue was admitted to the hospital for a severe heart attack, and this hospitalization was complicated by an ischemic stroke as well as a bloodstream infection. Since discharge, Sue has been admitted to the emergency room as well as inpatient ward several times for difficult to control blood pressure as well as chest pain. Lou, her husband, is her primary caretaker.
I have gotten to know Sue over the past 5 years while she has been on dialysis. Given her worsening health condition and changes in her quality of life, this seems to be a good time to start a discussion with her about what she might like for her future plans with regards to her care. According to our prognostic tool, she has a 40% likelihood of dying within the next 6 months, and she is within the clinic's high mortality quintile.
Today, we will meet with Sue and her husband to talk about her goals of care as well as her knowledge of her condition.
I would like to welcome you here today to our meeting. Thank you for making the time to visit with us. We want to learn more about what you understand with regards to your care, what your goals are, and how we can make plans with you for the future. We are doing a special project that's called Shared Decision Making and Renal Supportive Care, and you're part of that project with us. So we want to make sure that we're going to proceed in the right way to help you out. Okay. You already know me. My name is Jenny Kitson, and I'm the social worker here in the unit. And Dr. E is also part of the dialysis team. You know her as well. But for the record, perhaps we could introduce ourselves around the table here. Sue?
You certainly know me. I guess I'm the reason that we're all at the table. I'm grateful that you're using my first name. I really do prefer Sue, so thank you.
And I'm her husband, Lou, and we've been married for 40 years.
Well, no, it's going to be 38 in September.
Okay, dear.
Close.
And I'm Dr. E, your kidney doctor. And along with my colleagues, we've had the pleasure of taking care of you. And I'm hoping that today we'll start a conversation about the illness that you have, as well as how you've been dealing with it. This gives us a chance to start talking about how you see the future and your goals. And along with Ms. Kitson, who's taking the lead for our team in the conversation, we want to be sure that we're committed to continuing your care. We all understand that you are the most important person in this room, and it's your views and wishes that we mainly need to hear during this meeting. So, to make sure that we're on the same page, can you tell me a little bit about what you know about your health?
Well, I know that I'm on dialysis because my kidneys are not working. Before I started dialysis, I remember that you explained to me that I was not a candidate for a kidney transplant because of other diseases that I suffer with. Basically, you said that I was too sick. I don't know how long I can be on dialysis. It seems like I've been on for a long time. I gotta say, I hope I'm on it for a whole lot longer. I should also say, however, that life in general has gotten to be much more difficult during this last year since my hospitalization for a heart attack.
I hear what you're saying about the heart attack and having more difficulties. Can you give me a little bit more information about what that means, and particularly say something more about wanting to be on dialysis a lot longer? What does that mean to you?
Well, since my hospitalization, I have just felt so weak and tired that I'm not able to enjoy the things that Lou and I used to do together. We had a very active social life. We liked going out to dinner and meeting with friends. And the thing that scares me about what I'm seeing in our life is that my mother was on dialysis. And after a few years, she became so exhausted that she couldn't enjoy even the simplest of things like crocheting or even reading. She was miserable. We all knew she was miserable, but it kept going on and on and on, kind of like she was in purgatory. I don't want that for myself. On the other hand, I was very serious when I said I'd really like to live a whole lot longer.
And we want her to live a whole lot longer.
But you don't want me to suffer like my mother did, do you?
No.
It seems that Sue and Lou grasp that things are getting worse. We asked Sue in her survey whether she had any particular goals within the next 6 months. She told us that she hoped to see her 2 grandchildren graduate from high school, and we will explore this. She also wrote that she had a conflict with her husband, who wants everything done to keep her alive. He's clearly frightened of losing her, and he will need to gradually learn over time to accept her fate and the importance of letting her take control over her treatment. Thank you for sharing how you both have been feeling. I know that this has been a hard time for you, and it seems that you're both aware that your health status has worsened recently. Have either of you thought about what lies ahead in terms of your health?
I guess I have to be honest, I'm not sure I really want to know exactly what lies ahead. I think I have a sense of it from my mother's experience because she was on dialysis until she died, but I also suspect the treatment has probably improved since then.
Well, indeed, the treatment has gotten better, but as you know, there still is no cure. I can understand what you're saying with regards to the hospitalization not going great, but I've known you for a while now, and I know that you're a person that always has hope, but you're also practical and you plan for the worst. Is that a fair assessment?
That's very accurate. I am proactive and I'd rather be well prepared.
We're fortunate to have Ms. Kitson working on our team, and over the next few months, she will be able to figure out some steps for you to take control of your health. She will discuss with you some resources to help you and your family make plans for the future. From my end, I'd like you to follow up with your cardiologist to see how your heart is actually doing and to see if some of the new medications that you're on have been working properly.
The focus in this meeting will be on her cardiac condition, her treatment, and her medications. Due to time constraints, we will not be showing this on the video. I would like to shift the conversation to Sue's goals. And we are aware of the potential conflict that we might have with her husband, Lou, with regards to the treatment plan. This will not be pursued in depth during this initial interview, but this is an issue that we need to talk about in the future. You did a survey just before we started the meeting, and in that survey you talked about what you would like as a goal for the next 6 months. And one of the things that you mentioned was wanting to be able to go to the graduation of your grandchildren, right? Can you tell me a little bit more about that?
Yeah, and I'm not so sure how accurate I was in that survey. Our oldest grandson will graduate in about 5 months, but our younger one, it's going to be another 3.5 years before she gets her diploma.
Okay. But what's clear in this message is that your family is most important to you.
Absolutely.
And meaningful in your life. And you want to make sure that you can be there for the important things like this graduations.
And I do hope so. But, well, I think Lou and I had talked about it. We both feel rather strongly that the good Lord is in charge of making these decisions.
With some input from the rest of us?
Yeah.
I hope so.
Yeah, sure.
Good.
Okay, good.
Good. Sue, there are a number of things that we need to talk about during your dialysis sessions over the next few weeks. Such things as making sure we're clear about what your goals are, a living will, what a healthcare proxy is, and also a little bit about palliative care and what hospice services there are in the neighborhood. And Lou, it's important that you be part of this conversation as well, because we want to make sure we're all on the same page together.
Well, I know a little bit about some of these things, but I'm certainly willing to hear more, especially if it's going to help me and us as a family, sure.
It is important for us to know exactly what Lou and Sue learned from the meeting. Sometimes we as professionals assume that they understand everything that has been discussed and that they will remember what we have talked about. One way to test this is to use a technique that's called teach back, which we will use in this particular section.
Well, I'd like to take the time now to review some of the things that we've discussed in today's meeting. Sue, could you tell me in your own words what we've covered today?
I think what's most important to me is that you've given me an opportunity to share with you what is important to me, and that would certainly be my family. That having been said, and it's kind of hard for me to say this, I don't want to spend the last chunk of my life so exhausted that I can't enjoy that family that means so much. That's the way it was for my mother. and it was really kind of yucky.
I hear you, but I also want you to live as long as possible.
I know.
And that's why Dr. Amaka mentioned about you're going to see the cardiologist.
I know, I get it.
Sue has a pretty good grasp of things. She did not ask for specifics of her prognosis, but if she had, I could have explained to her and her husband that although she's chronologically 69 years old, because of her illnesses, her body is really older. According to our prognostic table, which will be supplied to you as a resource for such conversations, Sue's realistic life expectancy is closer to that of an 80-year-old woman. We have another instrument for you to use during these conversations, and it will show another way of looking at this. According to our calculation, Sue has a 40% likelihood of dying within the next 6 months. No clinical decisions were made during this initial meeting other than Ms. Kitson continuing to sit down with her at subsequent dialysis sessions to go through a checklist of advanced care planning.
I think you heard a lot during this conversation. Good for you. I also want to make sure that you know and restate that this is a team that's with you from the get-go. We've known you for a long time, and we want to make sure that we're going to make the right plans and the proper care for you as we go along making these decisions. Do you have any more questions for us?
No, you've given us lots of things to think about. It's been very, very helpful. I suspect we'll come up with more questions over the next days and weeks.
Great. Well, we want to thank you for taking part in this project, and we really appreciate your time, and I look forward to talking to you next time you're on dialysis. We'll have a conversation.
Thank you very much.
Thank you.
Thanks.
I also look forward to continuing this conversation with you both. And this information sheet that we have for you should do a good job of summarizing some of the things that we've talked
good.
about today.
Good.
Hopefully that'll be helpful.
Good. Thank you.
Thank you.
You're welcome.
Thanks. Thank you for watching the video. I hope that you picked up some pointers there. There are a couple of things that were mentioned that may be of help. As I was watching it, I recall that the survey tool that we used with the patient and the husband or family members may be of interest to you, and perhaps we can get that distributed at some point or made available. It asks questions about what is your joy of life, what are you looking forward to? As you know, they were making comments, and that gave the treatment team, obviously, the opportunity to be better prepared on how to focus the open-ended questions that they were asking during that particular interview. We also, can I have the next slide, please? Thank you. We also just wanted to point out to you that recently, there has been a very large literature review that had been conducted by Holleran, and they evaluated several of the articles and did a thorough, comprehensive analysis of materials that is available in the end-stage renal disease research field. And some of their themes that they identified resonate with the work that we were trying to do as well. So I just wanted to point out a couple of things that they're talking about, and this might help you in thinking about implementation. First one, don't make advanced care planning an add-on. It became clear to us that the social workers and other members of the team periodically would have the sense, even though it was a study that we were doing, that this is somehow additional work beyond what we should be focusing on, and that perhaps it belonged to the primary care physician or to somebody else. It's an integrated part of chronic illness, and it should be built into patient care planning, ongoing assessments. It's just part of the continuum of life. We're not immortal. So therefore, it's just something that needs to be incorporated in an uncomplicated, simplistic way as part of life. And we need to be aware, again, as Joan mentioned earlier, about, and this was noted in the research articles, about
one's autonomy and how that is viewed within the particular culture that individuals live in. And it takes work, and as they noted in the research literature, that discussing poor prognosis and death is just a difficult, emotionally draining subject, and one has to work at being comfortable in doing so. And advanced care planning is not really an intellectual task. It's full of emotion, heart-rending thoughts, and trust is needed to be able to move forward with these kinds of discussions. And in my opinion, they're talking about, the articles were mentioning approaching the vulnerable populations with empathy and skill. I think we need to approach all of our patients with empathy and skill, and clearly all of our patients are vulnerable. Next slide. So the project that we did involved 18 dialysis clinics, as we mentioned, and we were surprised at a few of the things that we learned as we were going along, and we just wanted to share that with you. The high turnover of social workers in the clinics that we were working in created a problem with regards to consistency of messaging and working with the patients who are participating in the study. We had 17 social workers that were initially trained. Again, because of the turnover, we ultimately ended up training 23 social workers, and in one clinic, they were unable to hire a social worker, so we actually worked with a nurse manager to assume that leadership role. And of course, as you can imagine, there was huge diversity in terms of the level of end-stage renal disease work experience that the social workers had from one clinic to another. The regional differences were noteworthy. In New England, we had a core group of social workers that were well experienced, long-term social workers working in dialysis clinics, and in New Mexico, many of the social workers were new and were still learning the, if you will, the internal procedures and protocols of what kidney disease is all about and the impact that it has on patients and family. So New England was able to have a peer support, informal support group where they were able to turn to each other for advice and help. In New Mexico, everyone felt as though they were struggling by themselves to get up to speed and to learn how to handle these discussions with end-of-life options. And we noted that there was clearly huge caseloads. I'm sure that you can all be sympathetic about and are shaking your head, yes, indeed. And then there are structural barriers that we noted. Please, next slide, and we'll talk about the barriers. As we mentioned, as I just mentioned, the social workers were commenting on their caseload volume. Some of the cases loads were as large as 150 patients, and lack of time to be able to follow up on these discussions was a clear barrier. The social workers commented on the business model in some of their clinics with regards to what they should be doing in terms of how much advanced care discussions should be taking place. I commented before that the conditions of coverage require that you provide patients the information about advanced care planning, but that may be all you do is just hand them a packet, and there's no time or opportunity or encouragement for discussion. Coordination, the lack of coordination across multiple providers was noteworthy. It takes a lot of work and a lot of time, particularly if you have patients who are in a nursing home. You have to coordinate with the nursing home as well in terms of common goals and plans. Also, if the patient is frequently going into the hospital, may not be the same hospital. And again, protocols are different within the hospital. So this is barriers in terms of fulfilling the desires and the wishes of the patient. And we also observe that in some corporate cultures, the social worker's role is key in terms of psychosocial analysis and support, community support services, but acknowledging the skills that are needed from the social worker with regard to advanced care planning is not necessarily supported. And we also, and I think you can shake your head on this one as well, there are some nephrologists who just really don't feel comfortable having these discussions with regards to option treatments and end-of-life management. And so that creates also a challenge.
Okay,
Slide.
next slide, please. Just one thing about the nephrologist. We had a comment from one of the participants today that her nephrologist is not comfortable talking about end-of-life care and about and is often wanting to talk about curative treatment. And indeed, that is a resistance, and a resistance that is very difficult to deal with, and another structural barrier. So what else did we learn from social workers? We learned that social workers really, particularly the ones in New Mexico, wanted opportunities to process the difficult feelings they had in their work. And all of the social workers talked about how difficult it is to balance hope with reality, some more than others. For some social workers, a place to talk about self-care was really important. We learned from our social workers that one deficit in their knowledge was around biological issues, and they felt that they needed more training around the progression of kidney disease. The social workers in the study gave us the feedback that they wanted their, if they were going to be trained in advanced care planning, they wanted their nephrologists to receive the same level of training as they did. And that was an interesting response. And also, finally, the social workers saw themselves as pretty competent on cultural and spiritual issues, but they did see the need for ongoing opportunities, formal opportunities for self-reflection, and that was also crucial. Okay, next slide, please. Next slide. Okay. So what are we saying that we think social workers absolutely, nope, back to, back one, please. Social workers, we hope, will take leadership in difficult conversations. And that means that there need to be opportunities for interprofessional leadership and training that promote collaboration. We also think it's really important that social workers learn how to assess some of the structural barriers in their organizations and in the larger institutions so that they can advocate for patients' values and goals. Next slide, please. Next slide. So as we did this presentation, we thought, okay, so it is really difficult work. But how do we do this in the time of COVID when we really want to help people not make advanced care planning decisions in a crisis, and yet we are living in a crisis right now. So we think that it's important that we talk about dialysis, advanced care planning as a part of a journey, that this is not, a series of crises, it's a journey, and that death is omnipresent, and all the more so in the time of COVID. And so in the moment that we're living in which any of us, all of us could be dying, we need to be continually assessing and reassessing what does the patient want, what does the family want, and we should be paying attention to the effects of COVID, and also how much are people grieving in advance of their own dying. And so we'd like you to think about some of the changes that you've seen in the time of COVID, as people are perhaps more front and center thinking about death and dying than they have had to in the past. Next slide, please. So obviously, we have always needed to be having advanced care planning discussions as part of dialysis treatment. But again, we know that often these conversations don't take place until there is a crisis. And then it's often too late to make a considered series of decisions. Again, because we're all at risk at this moment in time in terms of COVID, we should be all the more aware and mindful of how important it is for ourselves and for our patients to be thinking about advanced care planning. And again, we need to, for ourselves and for our patients, be more honest, more vigilant about planning for what is unknown and for our own deaths and those of our patients and our families. So I think COVID in many ways underscores how important it is for all of us to be thinking about advanced care planning. Next slide, please. All right, so what have we learned from our colleagues? We talked to a number of you in terms of what's it like to be working in dialysis clinics with minimally 6 feet distance and wearing a mask. Obviously, patients and staff are increasingly anxious, emotional, experiencing anticipatory grief. It's hard to have these conversations while wearing PPE. It's time consuming to arrange phone and telehealth assessments. And many of you told us how difficult it can be to hear your patients 6 feet or more away, or for them to hear us when we're wearing masks. And many of our patients are challenged in terms of hearing. Next slide, please.
Yes, to reinforce the anxiety level that patients are experiencing, we're just offering this quote that was offered by a Supportive Care Coalition member with regards to a survey that was done with patients through American Association of Kidney Patients. 78% of the patients viewed themselves as vulnerable to COVID. 84% indicated that their medical team had yet to discuss the disease with them, and let alone offer them how to protect themselves from contracting COVID. Now, this was done in March, and I'm sure by now a lot of work has been done with the patients, and you have a whole new protocol going on, but we're not done yet. As we know, COVID is going to be with us for a long time, and there may be a second wave. So the new term COVID fatigue is around, and it's something we need to be aware of and be ever vigilant and diligent with regards to how we're talking to and working with our patients, because we have a long way to go. Next slide, please. I'm concerned about our time, so I'm just going to go through some of these things rather quickly. What can be realistically done? If you have ideas, creative thoughts on how you might be able to use Zoom, other techniques, these conversations can take place in, not in the dialysis clinic necessarily, but other mechanisms that I'm sure you're now using. So make sure that you can get your medical director, hopefully fostering and supporting your ideas. If not, at least talk to your clinical administrator. You need to have administrative team buy-in to be able to do this sort of work. And as was mentioned, this needs to be a journey through time so that you can have these conversations with patients as they enter the program, and periodically just simply check in with them just to say, you know, how are you doing today, and have any thoughts, easy ways to open up the conversation and periodically assess where patients are at and what they're worried about, and have conversations with about their life goals as they might change through time. Next slide, please. Obviously, I'm sure you're all using as I just mentioned before, the technique of telephone calls and tools that might be useful to you. People are even have now assessment tools. If you go to the website that we offer at the end in terms of the Supportive Care Coalition website, they have assessment tools that are available there, as well as CDC with regards to evaluating the risk of COVID for dialysis patients. these tools are available. It might be helpful to give them to patients to review. Isolation rooms and conference rooms, depending on the structure of your unit, might be able to be used in a different manner than you're accustomed to, but I'm sure you're doing the workarounds as best as you can. Make sure that you employ community resources. You might be able to learn a little bit more in terms of patient goals, reaching out to people, primary care physicians, spiritual leaders, ministers, the visiting nurses. All of these are good resources that you can use. Also, patients should be having emergency packets with regards to information about their advanced care plans, contact information that they can take with them, because as you know, with COVID, your change in terms of your clinical condition can just happen so rapidly that there may not be any time to gather information. So a packet by the back door, having contact information is an easy way to make sure you can put it around your neck and have it if you have to call for the emergency assistance in any way whatsoever. Next slide. And of course, the basic principle to all of this is listen, listen, listen. We have to start these conversations and tell people that we know that it's a complicated subject, but we want to be sensitive to everything that they're experiencing. Listen to their concerns, their level of suffering, pick up on observations with regards to comments having to do with death anxiety, and just simply becoming more and more of a burden. These are all key signals for an opportunity for you to start a conversation with the patient as to what they really are worried about. Next slide. Joan?
Okay, so in light of our time, I think it's let me summarize that it's really often the case that the social worker becomes the container for ambivalence, for anxiety, for sadness, for anger, and for trauma and for loss. And there is a cumulative weight of so much suffering that often we, the clinicians, end up feeling. We need to remember that we cannot fix, we cannot take away people's pain and anxiety, but we can be present. Next slide, please. It's hard, however, to be present. And again, it's hard to listen for and to the sadness, the grief, the loss, the trauma, because in dialysis clinics, there's often a culture of life. But we have to resist, unrealistic optimism. We have to be open to hearing suffering, and yet it requires that we also take care of ourselves. Next slide, please. So what do we do to stay, to relentlessly take care of ourselves? Well, we have to recognize our compassion fatigue. We have to, as we said earlier, engage in forms of self-reflection. It may be supervision, it may be debriefing, it may be staying connected to our colleagues and to informal and formal networks. And that takes work and it takes courage. Next slide, please.
With regards to recommendations, again, just sort of quickly, because we're running out of time, it's very clear that at the master's degrees level and at the corporate level, end-of-life training is not being offered, and it needs to be incorporated into the training program. And that we need to have that kind of training also available on an ongoing basis at regional and national meetings. Next slide. The role of the social worker as an expert in palliative care needs to be developed and recognized as the appropriate role for the social worker to have in a dialysis clinic working with chronic patients. Peer support groups is a major resource that is needed to help social workers explore their own feelings with regards to doing this difficult job and learning from each other in terms of skills that can be utilized in taking care of your own patients, and an opportunity to have a chance to reflect on the work that you're doing. Next slide. Again, resources are available and you can obviously turn to them to understand the legal issues, and all of that needs to be made available through your corporation or through your professional organizations. I hope that the Council of Nephrology Social Workers has picked up this gauntlet and is helping you with regards to having a voice about your important role in this regard. Next slide.
Okay, so let me just say in conclusion that we are key team members. We know about legal issues, ethical issues, spiritual issues, psychosocial issues, but that means we need to step up and take leadership. We need to be able to continually ask about the patient and family's goals, and we have a duty and responsibility to help our patients, to be with them through the disease trajectory, asking and re-asking, while also recognizing their strengths. Next slide, please. Again, if end-of-life care is limited, we need to advocate for further training, and training that includes self-reflection, legal, ethical issues, diversity. And again, we can't say enough that we think that corporate management has to support systematic advanced care planning education across regions and levels of experience. Next slide, please. Jenny?
Oh, all sorts of resources that we were talking about in terms of reference material for you to look at. Obviously, we're not going to review all of this, but I think there's places that you can go to educate yourself in terms of promoting your role within the corporate structure in terms of advanced care planning. Last slide, please. And resources. The Coalition for Supportive Care has a lot of materials that can be used for patients as well as for professionals in terms of tools to do with self-analysis, self-evaluation. The Center for Disease Control also has tools with regards to dialysis patients in the era of COVID, questions that can be asked with regards to how to protect the patient and themselves in the clinic as well as at home. The Conversation Project has, again, tools made available in terms of how to have these kinds of difficult conversations. And the American Association of Kidney Patients also has webinars that they've been conducting around COVID and that are being sponsored by patients and getting helpful tips on how to take care of yourself during this troubling, stressful time. And of course, make sure you reach out to your local end-stage renal disease network.
So thank you, everybody. And yeah, and take good care of yourself.
Thank you both for this very important and extremely timely webinar. I'm sorry we ran a few minutes over. I want to let everybody know that slides are available to any participant who requests them, and we also recorded this webinar. So as you exit the webinar, you need to click on a continue button that would take you to an evaluation form. And thank you all for completing the evaluation form now so you can receive your CE credit. Hopefully you all have a very nice rest of your day. And thank you again.
Thank you.
Thank you. Bye.
Bye.